now we're going to see how things have worked and the evidence of the results of this 6 years of work. So we have invited Holm Grasner, the ERN R&D coordinator, Ruth Ladenstein, she's PETCAN coordinator, and Ignacio Blanco, who is a doctor at the Hospital Germán Trias y Pujol in Barcelona, and he is part of Genturi's ERN. So the three of them will give us a vision of the evaluation results of the networks and healthcare providers. Holm will start with an overall vision of the evaluation in all ERNs and encompassing the whole process, let's say. Then Ruth will look at the results specifically for her ERN and how that process had felt in her ERN. And Ignacio will do the same from a healthcare provider perspective, and he'll share with us how he lived the evaluation and the results and etc. So after that, we'll have a small comfort break. The comfort break, I think, I'm afraid we have to reduce it a little bit. So when we get there, I'll let you know. But probably will be a 10-minute break or something like that. And then Matt will take over with a panel discussion. So if you have any questions for the speakers, just type them into the chat, and then they will be able to respond to them during the panel discussion. Okay, if that's okay, we'll just go, through the presentations as we go to catch up a little bit. Okay, so without further ado, Holm, the floor is yours.
Yeah, thanks a lot, Ines, and also Jan. Thanks a lot for the very nice and very comprehensive presentation of what have. So I think the past and also the achievements of the ERNs so far. That's really appreciated, and I have to emphasize that this is really now a status where which we have to use to get what I call integration ready. So I think the next big step is really to integrate into the national healthcare systems, and that's a task for both sides. It's not only a task for the member states and the national healthcare system, it's also a task for the ERNs. So we need to get integration ready. So, but that's just my pre-word, so to say. What I now will be doing, I will be focusing on the ERN system and evaluation. And I think it's important to understand that I just focus on evaluation. So I have a few negative things to say. But I don't say them reflecting what the ERNs are, and don't reflecting the ERN system. It's really on evaluation. So let me start, and then you can ask question, and we can discuss also then later in the panel discussion. Okay, here we go. So I've been asked to take the perspective of the ERN system, and first I was wondering what actually the ERN system is. And as far as I understand the ERN system, it has quite a number of participants. Of course, the open reference networks, the ERN units at the different hospitals, the ERN coordinators, and the ERN coordinators group. But also, I think it's important to add hospitals, member states, the board of member states, ePAGs, the ePAG steering group, patient organizations, EURORDIS, EG Sancte, and HADEA. So I think they all belong to the ERN system at large. And I think it's really important to also understand that the ERN system is not only about the ERNs, but really encompassing all these participants. So where and what are at the moment the core activities, the funded core activities of the ERNs? So they mainly focused on cross-border cooperation of the ERN units, facilitated by the ERN coordinating offices, and they were focused on coordination, on cross-border healthcare, so CPMS, virtual advice, on training activities, on guideline production, appraisal and endorsement, on care standards and on registry. I think those are the core activities, and I should also add the patient journeys. And as Jan has presented, we achieved quite a number of very remarkable and I think very important results in focusing on those core activities. So now, if you look at the evaluation, and if you want to evaluate the ERN system, what actually was the focus of the evaluation were the ERNs, the ERN units, and the ERN coordinators, and all the rest are the rest of the participants, and I would even say the essential participants of the ERN system were not targeted by the evaluation. So neither the coordinating group, neither hospitals, member states, board of member states, ePAGs, ePAG steering group, patient organization, ERNs, DT Sancte, HADEA, etc. They were all not the target group of the evaluation, just the three you know of. So the focus, however, was the entire ERN system. And that led to a few things. So my first conclusion is that although the ERN system was evaluated, the ERNs, the ERN units, and the ERN coordinators are only accountable for a part of the ERN system. And you understand that when you look at the respective participants of the ERN systems. However, and that's how the evaluation was set up, the ERNs, the ERN units, and the ERN coordinators were evaluated as if they are the entire ERN system. And that leads to my second conclusion. So the evaluation of the ERNs, so the funded European level of the ERN system, led to very good results. And this is actually an indicator for the mature level of the ERNs. And as Jan has pointed out, so I think as regard the ERNs as European reference networks, we are in a good situation. However, the evaluation of the ERN units, so the unfunded local and national level of the ERNs, led to a lot of frustration. And that's because they were evaluated not only as ERN units, but as hospitals, as member states, etc. So this, well, I think is a part of the evaluation we have to consider when thinking and also improving the evaluation. So, but let me start with the outcome. Although I started off with well, putting the evaluation in the context of the ERN system. So I think by and large, the outcomes of the evaluation are very positive. So all 24 networks obtained satisfactory results, and all the networks are therefore maintained. And this is, I think, really a proof that the ERN system works on the level of the networks. And then you see that the vast majority of the healthcare providers which are part of the ERNs, or I should say the ERN units, were positively evaluated as well. And then there are well, a low number of ERN units which were assessed, evaluated, so that they now need to, or they had to come up with an improvement plan. They have submitted an improvement plan, and they now will be re-evaluated after a year's time. And there are a few healthcare providers, a few ERN units, which is, well, really a very little minority of the ERNs which didn't pass the evaluation, which is okay, because if you do an evaluation and you do a right evaluation, then I think the expected result is that not all ERN units or not all healthcare providers will be passing the threshold of evaluation, and consequently, these HCPs were in terms of membership for the ERNs terminated. If that is really reflecting their value in terms of ERN participation, I'm not sure about. But that's maybe not, maybe will be part of the discussion later. So they did not pass the evaluation as it was set up to evaluate the ERN system. Okay, so what are general remarks I would like to give based on the evaluation and taking again the ERN perspective? So first, the ERN evaluation was necessary based on the legal framework we have, and the ERN passed this test. So it's a really important milestone. And as said, I think this really proves the maturity of the ERN system on the level of the ERN networks. Then, if you look at technical goals and evaluation, I think there are three. So first, it's to measure against criteria. We certainly did that. Then it's to understand, and understanding means identification and analysis of mechanisms by which the outcomes are produced. And C, third, it's to learn, and to learn how the program will be improved and can be improved. And this actually works as long as the framing of the evaluation and the evaluated program are a good match. And I wonder if that's the case on the level of the ERN units, so on the level of the HCPs which were evaluated. So, and this is actually reflected by the results of a survey. We asked all ERNs to give input at, and we asked a number of questions. So one question we asked, what were the three main issues faced by ERN HCPs, or let's better say ERN units, regarding evaluation. And the main issues were, the main focus was on the hospital, not on the expertise center. There was no coordination with national activities. So where there was no support from HCP management, administrations, language was an issue, mainly because the translation of the documents and the translation of the interviews being done were requested, and the costs were to be bared by the ERN units. There was some missing clarification on the formulation of some measurable elements, and then the time needed for the evaluation was an issue. And also, based on the things before, the relevance of the evaluation was being questioned. So when we asked also what went well with ERN evaluation, I see the responsivity and the friendliness of the auditors what was mentioned. So there's no substantial positive remark on the evaluation. But we also asked what can be improved, and that actually reflects what has been identified as issues. So in summary, what they would request is a revision of the ERN evaluation to focus on the specific expertise required, to be a member of a specific network, and on the actual participation of the HCPs in the activities of the network. Then second, take into consideration national systems and avoid overlap. So maybe perhaps even leave the evaluation of the HCPs or the ERN units to the member states altogether. Then focus on evaluation on structures and processes that ERN units can change or improve. You see the point I made when I started my presentation. Then there was some but also some issues about homogeneity of the evaluation. So at some hospitals at which different ERN units were evaluated, the evaluation of the same evaluation information was different from ERN to ERN. Then the fifth point was actually request was to align the ERN evaluation with ERN monitoring. So build an integrated system so that things are not being done twice, but in one system. And the sixth request, and I get back to that, is really to involve the ERNs in the improvement of the evaluation and form a respective working group, which involves the ERN coordinators group, the board of member states, and DG Sancte. And I would also add actually Jardin as a joint action. So we also asked what time was being spent on the evaluation and taken into consideration the issues I just mentioned. So I think on the ERN coordination office level, so on average, bit less than 200 hours, about 2 per month. I think that's, I would say, more or less okay. But if you look at the HCP level and having taken into consideration that the preparation and also the performance of the ERN units on HCP level was being done by the ERN experts and not by the hospital administration and not by the hospital hospital managements, and then you come very quickly to a number which I think is a bit scary. So if you do a very conservative estimate of what time is being spent and what money is being spent on this evaluation, you get to well, a number of more than 8,000 patients, which could have been seen in that time, which was being spent on the evaluation just for the audits. And you also get to an amount of money which is equal to that, which is more than €500,000. And that does not take into account all the document preparation which was done by the ERN units which did not receive an audit. So my consequence, and that's my last slide of the evaluation, how it was done, is that we need a systematic evaluation of the evaluation. And the mean really to do that is a joint working group on the improvement of the evaluation, so that the evaluation of the ERN system is really a evaluation of the ERN system, and not just well, I would say the most important, but not by no means the entirety of the participants in the ERN system. And by that, I do thank you for your attention.
Thank you, Holm. Thank you for that. That was very interesting. So now, Ruth, if you're ready, it's over to you so that you can present the results of PEC and ERN evaluation. You're muted, Ruth.
Coming. Thank you.
There you go.
So so I think you can see my slides, right? Hello, can I start? Can you hear me well?
Yes, Ruth, go ahead.
Okay, thank you very much. So I will give you some insights in ERN PET-CAN and our experience, particularly with a focus on evaluation, with some explanations on top what we are heading for in a larger vision. I think it's...
Sorry, I don't think we can see the slides, so I don't know if others are, but...
No.
You
No.
cannot, or you can?
We cannot.
Interesting, because, okay, sometimes it's...
Now it's coming.
Okay. You see them now?
Yes.
Yes.
In a good mode?
No, not yet.
Okay.
Yes.
That's good. That's good.
Yeah?
Yep.
Okay, sorry. So coming back to our PET-CAN mission, as we defined it early in the beginning, for us it was extremely important to keep the reduction of inequalities as a key motivation. And this has to do with the long-standing history of pediatric oncology, which is goes back almost half a century, and major improvements. But inequalities are an issue, and hence to enable really access to up-to-date diagnostics and treatments is absolutely key. And hence we were aiming to facilitate exchange of expertise and knowledge. A second point for us of high importance really was, as we're dealing with children, with families, we wanted to ensure that information travels rather than the patient, because for a lot of consultations, it's just bothersome to take the journey. If you can have good information, for example, through the virtual tumor boards, and I'll come back to this later. The idea is really to unite the specialists across Europe through this cross-border activity in an enhanced way, in spite that we already have 16 active specialized tumor groups with a lot of sub-entities that are already covered. But to put really patients and cross-border advice and inequalities in the center to help patients was our main interest. So we are one of the largest networks, as you can grab by this oversight, with 92 full members and affiliated partners. So this is a huge number, and this is just gives you, I don't go through all the other numbers, but in a comparative way, say that we have, in terms of outreach, a huge community to address. In another way, what is the member status across Europe within ERN PET-CAN? So you see in orange in the upper line the countries with full membership. In part, it's proportionate. It has to do also with our history. One needs to understand that Germany was one of the major drivers in the development of clinical trials and protocols. For sure, not the only one, because strong contributions are coming here, most definitely from Italy, from UK at the time being, which sadly is not yet back, not in the Sci of Europe community where they always stayed, but not possible to embrace them currently in the ERN activities anymore for reasons that you know very well. France, with also being a major driver in the development, and I apologize not for naming all the others. For us, it was very important to embrace affiliated partners in countries that we call widening countries. This is the upper line, Bulgaria, Croatia, Cyprus, Estonia, but also Luxembourg, Malta, Romania. And these are really very important interactions when it comes down to twinning activities, to education, and particularly when we focus on inequalities. So you see we have in total 52 full members since 2017. These are our 56%. New full members when then a new call came out, adding on another 29, 32%, and 11 affiliated partners. So yeah, probably also to say this evaluation went towards the full members, and the exercise was huge. But some more KPIs. What can we capture in terms of number of patients and cross-border referrals when going back to the HCPs? And you see a steady state in the first years, roughly in the range of 6,000 patients, then gradually moving up to 7,000 in the COVID years, coming down a bit, but marginally, just by about 1,000 patients, and then higher activities in 2022 with 10,000 patients. So indeed, there is a high number of activity within ERN regarding to cross-border activities. Since we are focusing here on the evaluation of the 5 years, the first 5 years, and not of the bridging period, this is for another time. This just gives us you the basic concept, what was our focus. So one of the priorities was to develop a roadmap which particularly refers to patient pathways. And how did we do it? As over time, and we were working ultimately on European standard clinical practice guidelines. And this was a major interaction between all the European clinical trial groups, delineating what they are considering as best standard practice care guidelines, particularly when either no randomized frontline protocol is open. And just to give you a clue what we mean with randomized phase 3, usually these are protocols with multiple randomizations that recruit between minimum 500 up to 2,000 patients and more. And and they are complex, and that's why we felt we need also a standard protocol reference for all this country that cannot have deliver on all the complexities of multiple randomizations, but have a standard best practice recommendation, which will help us to bring also equality in terms of treatment aspects. There's a strong work with our patients and survivor organizations, unified also through CCI Europe. They are also present today, and they map the landscape of active organizations across Europe. Is a huge and beautiful work that we started in the next period, even more so to capitalize on. The virtual tumor boards in the beginning with the CPMS, I think it goes into the right direction, but it was somewhat hampered that a community was not yet completely used to virtual tumor boards, and the access was quite bothersome, sometimes limited access for those who needed it the most because they were on guest status and not full ERN members. So I'm not going into depth, but we welcome very much the great improvements that we expect from the CPMS revision in being more user-friendly with a lot of new functionalities. We had a number of twinning programs ongoing, and in particular, we are proud just to have helped Lithuania to gain the project lead in the so-called TRAIL project that they beautifully delivered with actually the project lead in Lithuania under Jelena Raskom. And we have a big topic, which is the survivorship passport rollout, also a long story with multiple funds, where we actually want to achieve that the patient's history is captured in a nutshell, treatment burden that accumulated in first and or second line treatments, and translate this then into recommendations of best care options for long-term follow-up, as we are lucky enough to have these days now long-term survivors, but with a huge burden of late effects that increase over lifetime up to 60%. And this is meant to be ideally an electronic instrument that will be within the health systems. So wherever the survivor later on in life will have a touch point with the health system for specific needs, the information would be ready and everybody would be informed, so thus having a better supportive care in the years to come whenever needed. Knowledge sharing and dissemination we did in multiple activities, in not only in meetings but in webinars with multiple focuses. And the very rare tumor integration was about building a specific registry for these very rare tumors within pediatric oncologies, and a full network that interacts beautifully and also integrating national levels towards a European level. So all this together leads to an increased best practice sharing and also a better training and capacity building overall. So this is it a little bit by content. So for the evaluation, I think in many ways, I may echo what Holmes just said. We understand very much that there needs to be a measure if there is an investment, so this is not surprising. And I think what we always wanted to bring also to the table, that we rather would have seen that such systems are developed also in a cooperative attitude, and rather than from the outside, so NIBL and the Amicus consortium were creating a lot of variables, what they felt is best to measure. And we are not necessarily sharing the views, because the impact burden was enormous, as Holm just demonstrated very nicely. And we were wondering, nevertheless, about the added value. So we had multiple questions, which I think basically are justified. Did we achieve our goals? And how well are we covered? And this is just to mention that we are quite proud in ERN PET-CAN that we have European-wide coverage, including political Europe widening countries, and to contribute continuously to a better care and interaction. We have shown you numbers of particularly cross-border healthcare evaluation in my first slides, and a lot of education materials, etc. So we could show all these parameters. But what is the evaluation experience from our side? There was, first of all, a very complicated and lengthy guideline how to run through the experience. I mean, it's interesting if you have to study 281 pages first with an evaluation toolbox of 152 pages, an evaluation manual 34 pages, frequently asked questions, and so forth. So lots of instructions. A portal that is not very user-friendly, and I really have to give a big applaud to my ERN team here. This is particularly Zoltán Doba, Martin Schalling, and more recently Adriana, that help to run all these multiple interactions. And without them, this work possibly couldn't have been done. So we had a self-evaluation out, but to drive the process. But overall, for the positive things, the evaluation team was friendly and helpful. They responded quickly, and we had the special pleasure to be audited not only when we started, but we also had a re-evaluation face-to-face in our hospital, and I can reassure you the preparative work is enormous, and you have to have a lot of goodwill to invest in these audit processes. So this is just quickly in a nutshell, lots of formular self-evaluation forms and many documents to be supplied, to be shown, to be uploaded, etc. So when we look into this, what our evaluation gave, what are actually the insights on these 5-year working plans, we have met all our goals effectively. I think we were able to deliver also, and as well as on the outreach overall. And on the member state level, I think very much we are talking about the HCPs that are delivering the care and to facilitate the cross-border interactions. I mean, has been through the clinical trials already quite a long development in pediatric oncology, but we were able really to foster it and bring it to the next level. Again, a little bit light on the efforts. It was almost a 2-year process to get everybody ready for these evaluations, with templates and guidelines to be circulated, and follow up with dedicated session. And it absorbed 1,000+ emails to run the whole process. Our result was satisfactory. We had the majority of criteria also acknowledged as fully developed, with a few partially developed. Some of this referred to the CPMS, but the reasons for that are very well known to the ERN community, and we hope for the better with the things that are coming. So in the various areas, you can see we scored very well in governance, clinical care, patient-centered care, contribution to research, education, training, network and dissemination. Quality and patient safety was not an issue per se, but the Commission wanted to see more documentation work, more questionnaires out to the patients, and this is certainly something that can be enhanced, but not that it was missing at all or overall. So again, I think a lot of those things are already mentioned. Governance and coordination of such networks, and this is what we are receiving funding for. You have to remember this. This is a coordination action. We are not presenting the HCPs per se, but we are motivating them to deliver. And as it just crosses my mind, also aligned what Holmes has mentioned, if some HCPs didn't buy in, you have to remember that some have to go to a double and triple certification process because they have it on a national basis. They might have another one reflecting their specialty, and ERN PET comes on top. And sometimes teams are just tired of running audited processes continuously with a lot of duplication of efforts that take them away from clinical work and patients. So I think this is, a common message. We have in the meanwhile here in the 5-year period, it was 10 ESCPs. These are these European Standard Clinical Practice Guidelines, which are on the respective web pages of our web page, but also accessible for all SIOP Europe members. Currently, we have already 23 of them online. We developed in the later period also a registry that is about to get started so that we can capture the baselines, and there are more to come as we will go up to 30. I think patient-centered care is in the core of our mission ever since. And it's having further developments in sharing practices and bringing from countries often for the reasons of being economically disadvantaged, also a factor that you have to take or embrace to onboard them and bring them to the next level. And one really has to say that patient advocates in respective country do an incredible job to foster this. The other things I have said, I think, we can go over this quickly because it was demonstrated already by the respective activities. So our final results is continue also in the evaluation phase. We supported largely those HCPs that needed to be helped, encouraged. And again, special thanks to you, Sultan, because you're in endless energy, supporting, giving guidance to all those when they get frustrated, and it wouldn't have worked as beautifully as it did without your continuous support. So this is actually the last summary. So we had were confronted with this evaluation system, and you will remember my critical remarks. Overall, we appreciate that it has increased the accountability of the ERNs. It has demonstrated patient-centered care across Europe in the respective member states. A lot of benchmarking was done to profile the active HCPs. We have harmonized and undertaken major steps that will pay off over the years to come, also through the ESCPs. And so there are numbers of opportunities how you improve further the efficiency of the ERN system. So with thanking not only my team, but the huge work of all the teams in the HCPs, I want to stop here and thank you for listening.
Thank you, Ruth. That was Oh, it's brilliant. So now we're going to listen to one of those clinicians that went through an audit and what that meant for him, what he learned, and what type of effort he put into it. So Ignacio, over to you now, and we're all ears. Go ahead, please.
Hi, good morning to everyone. I will try to share my screen. And first of all, I want to say thanks to invite me to share with you our experience being evaluated as a HCP. I hope, can you see my slides now?
Yes, there.
Okay, perfect. Okay, I will try to be on time because we are late. As you know, the evaluation process is it has been a very complex process, having preparatory steps, but also a self-evaluation, technical evaluation, and a final resource. As a HCPs, we have been evaluated, and I think that we need to be evaluated in order to be sure that we, as a HCP, continue to provide specialized and quality care. Also, that we maintain the necessary level of activity and experience, and that we contribute to the network, and also to know if the network is contributing to the HCP. To evaluate the healthcare providers, we need to verify to which extent the healthcare providers meets the quality requirements. And these quality requirements were formulated as a criteria. And each criterion is followed by a list of measurable elements used to assess the specific aspects of level of performance. Some of these measurable elements were considered as a core, and this should be accomplished or implemented during the evaluation, and all the others refers to important areas in order to know the maturity status of the HCPs. All the criteria were grouped in several areas, and the independent evaluation body set up a list of criteria for all HCP teams. These are the criteria. We have 24 operational criteria with 64 measurable elements. 29 of them are core, and they cover 7 areas: patient-centered care, organization and management, research, education and training, exchange of expertise, quality and safety, competence, and human resources. As you can imagine, there are many, many measurable elements, 64. During the preparatory steps, we got the opportunity to have a good evaluation manual and a tremendous evaluation toolbox, but also very complex. The toolbox is a collection of 18 items, including guidelines, form, templates, reference, everything, etc., etc., etc. Many pages. Our HCP evaluations could be done in 2 ways. One will be a documental review, where the independent evaluation body will have 3 types of documents. The initial assessment of the application for the HCP that has to be provided by the European Community, the monitoring indicators provided by the members of the ERNs in the last 3 years, and it has to be provided by the members of the ERN, the coordination team, and also the information and evidence that we have to provide to the EAB. Some of the HCP receive an on-site audit where auditors can collect supplementary evidence needed to accomplish all the measurable elements. Not all HCP receive the on-site audit. All these operational criteria can be classified as a core measurable elements that has to be evaluated during the on-site audit, and some of the operational criteria reflects the contribution of the HCP to the mission of the network. And all of these elements can be characterized or classified as a non-developed, partial developed, 1 point, and fully developed. Here you can see some examples of core team measurable elements, elements to be evaluated during the on-site visit. Some elements are core and should be evaluated during the on-site visits, but we have to answer, although we don't receive the on-site visits, and these are other examples of these measurable elements. We as a healthcare providers should have a self-evaluation document reflecting who we are, what kind of diseases we are dealing with the different specific conditions, and also to reflect the indicators of the network. We have to provide a self-evaluation of all 64 measurable elements and provide documents to prove the development of these measurable elements. There is a long list of documents, list 35 documents that we have to upload to this self-evaluation. As I told you, during the on-site audit, the reviewers or the auditors can look for additional aspects. And it's a very short audit, 1 day only. As you can see here, there is a presentation. There is a presentation of the multidisciplinary team, and also there is an interview with professional and patients, and a very short review of medical records to be sure that all aspects are covered. And at the end, there will be a feedback to the patients. In order to obtain a satisfactory result, as a HCP, we have to score 1 or 2 in the 90% of the measurable elements considered as a core. And there has to be only 3 as a maximum measurable elements that were scored as a 0. Also, an HCP has to score at least 70% of the highest possible score in the core of the core measurable elements. This means that you have to get at least 40 points to these 29 core measurable elements. Saying that, our ERN, Genturis, recently received a satisfactory evaluation. We got as a complete ERN a final report of 100% score and some remarks from the evaluation body. You can see here, there is a sustainable structure, excellent management, coordination between members, active participation in the CPMS, a functional registry, and several research activities. And we also receive the report as a HCP. We receive a preliminary satisfactory results. And also here you can see the final evaluation report. And I can share with you that we were surprised because in the first page with a strange, we were notified that the evaluation suffered from two limitations. Many of the documents produced are in the national language without English translation. We have to deal with patients in Spain. And also, as it was a survey, and we didn't have on-site audit, many of these elements were not, the auditory team cannot be sure that this is true. We were surprised that these are strengths of our HCP. We got good reports from the 7 different areas, and we also received suggestions for improvement that I'm sure that they will help us as a HCP. In patient care, we have to involve more patients in the care process. That is a very good suggestion. We have to collaborate more in the registry. We had a lot of problems to implement the registry in our HCP. We should better implement the procedures for telemedicines, and we should record better the competence, experience, and outcome of care. Here you can see our numbers were good, I believe. And this is the final and different evaluation of the core and non-core measurable elements. I would like to give you my personal opinion of the process. And first of all, I think that it's important to acknowledge that the evaluation process is necessary. It's crucial to demonstrate that we as a HCP provides a specialized and quality care, that we maintain appropriate healthcare activities, and that we contribute to the ERN, and also that the ERN in turn contributes to our HCP. However, having said that, I believe that the process is excessively bureaucratic. It requires the submission of a lot of documents to evaluate the 64 measurable elements. And some of the documents must be completed in the original language and cannot be adequately accessed. Healthcare professionals are not used to audit processes. I'm also a clinical director of a lab, and we accomplish ISO guidelines in our lab, and I was used to this process, but many of the doctors are not used to these audit processes. We as a healthcare providers lack administrative support to facilitate the preparation of documents. Despite the creation of the helpful manuals, it will have been advisable to better prepare HCPs for this process. In my opinion, it will be beneficial to promote a continuous evaluation process. Many of the documents can be provided during the years, and progressively assessing document. And we should expand the on-site evaluation visits. And I'm sure that you will agree with me that it is very important to include patient experience evaluation in the assessment of ERNs, but also it will be crucial to evaluate the experience of healthcare providers who are part of the HCPs. And I think that I will leave for questions if there are. Thanks a lot.